What's up, Des Moines? Doc Ladd here with the Fit Moines podcast. Today I'm joined by Dr. Todd Peterson. He's a board-certified orthopedic surgeon specializing in sports medicine, joint replacement, and conditions involving the hip, knee, shoulder, and elbow. A Des Moines native, Dr. Peterson trained at Des Moines University, completed his orthopedic residency in Detroit, and fellowship training in adult reconstructive surgery at Southern Illinois University. He's now back in Iowa serving patients at Capital Orthopedics and Sports Medicine while also teaching at Des Moines University. Today, we're diving into sports medicine, orthopedic surgery, healthcare costs, and separating what actually works from what's just hype. Dr. Peterson, thank you so much for being here.
Yeah, thanks for having me, Brian. This is fun. I love talking about all this stuff.
Yeah, absolutely. I'm excited to dive in here and learn a little bit more about you, and then we'll get into some fun topics, I'm sure.
Perfect. Well, hopefully I don't disappoint. I'm not the typical orthopedic surgeon. I come from 0 doctors in my family. My family's a bunch of painting contractors here in the Des Moines area, and I did that to help put myself through medical school. So maybe I come with like a little bit of a different perspective.
Yeah.
I'm a big cheapskate. And so a lot of this like medical costs as a patient, I couldn't believe.
Yeah.
That's kind of one of my passions. So anyway, that's my general overall thought process towards orthopedic surgery.
Yeah. Well, I like that background because it does give you kind of some insight into what the everyday person goes through. And several discussions I've had from recent podcasts have been on price, and transparency has been a big part of that as well.
Yep.
So
Yep.
yeah, let's hop into it. So healthcare costs, as we know, are out of control, yet some surgeries can be done dramatically cheaper outside of the hospital system. Why is that?
So that's honestly, this is one of my passions. And what this is all my opinion, but the American Medical Association and the American Hospital Association have a pretty big presence politically. And the government has made certain laws, if you will, bills in Congress that have allowed hospitals to charge more. And they justify it by saying, and I'm not pointing fingers, but they justify it by saying, hey, well, we have to stay open 24/7. We have emergency services. We got to keep people on call. So our costs are more expensive. So we should be justified to charge more. However, if me as an individual surgeon goes to an insurance company and said, hey, I'll do this exact same surgery, the exact same everything that the hospital does, and I'll do it. And they're like, well, sorry, you're not a big enough player for us, so we're not going to give you any special contract. But I said, well, I can do it for a third of the cost because I don't have all the overhead the hospitals do and all that. So, that's one of the biggest things. And so you think the insurance companies would be loving this because if I can do let's just say any sort of joint replacement or an ACL or something for literally a third to a fourth of the cost, they would be jumping all over that, but they're not because the insurance companies and the hospitals, they like to keep their costs where they are because that's how they're making money. So we've gone through a lot. I mean, we've even been through obtaining our surgery center and our certificate of need to serve patients just as physician owners, not at a hospital system coming in and being half owner of the place. We were, the lawyers for the hospitals came after us and they tried to keep us from getting that. It was really interesting. And this was about 7-8 years ago that we did that.
Wow.
So, but now I'm very proud that we've established this and it's a way to give cheaper costs because we have less overhead expenses and the insurance companies, just to be honest, won't pay us as much. So it's to the patient's advantage.
Yeah. Yeah. It's so interesting, even from the physical therapy side, the hospital system, physical therapy is doing the exact same thing.
Yep.
We're coding the same thing, but they're getting paid more. And to your point, from a preventative side, like we could save insurance companies a ton of money by preventing these big injuries or even in some cases the need for surgery, but they don't want to pay for that preventative side.
Or they want to pay for it when it's not needed, when they make me do 6 weeks of physical therapy, no offense, but if they make my patients do physical therapy before they even get imaging.
Yeah.
Well,
6 weeks. 6 weeks of PT before that MRI that we already know is necessary.
Exactly. So I don't know. I don't understand that. And that's been a big frustration for me. So that this whole impetus made us go out and just kind of do our own thing. And I will brag a little bit. We're the only wholly physician-owned surgery center in the entire metro area. Every other practice is half or slightly more than half owned by a hospital system. So to me, that gives us an advantage because we can lower costs.
Yeah.
We don't charge those elevated prices that hospital systems do.
Sure. Yeah, that's really interesting. I didn't realize that. Along those lines, what's something most people completely misunderstand about orthopedic surgery and sports medicine?
Is that I think one of the things I always see is like if you go and see an orthopedic surgeon, that means you're getting surgery. Absolutely not. I mean, I
Yeah.
that's one of my tools that I use to help people. But if you want to come and just get a good diagnosis, I mean, you probably know this too. You just get sent someone by, a primary care doctor or some other physician that says, "Hey, they have shoulder pain," and you're like, "Okay, well." You trying to do your evaluation, and you're like, well, it could be this or it could be this, and it may help. Your treatments are great, but if they have some sort of a tear or something of whatever it may be, or arthritis, doing PT may not do a whole lot, and they need a good diagnosis. So I see so many people that have come to me, months and months after they've gone through all these treatments, and maybe they're scared to see the surgeon, or maybe they, for whatever insurance reason, they had to do PT first or whatever, as we were saying. But
Yeah.
I just see so many people that I come and like, hey, if you would have seen me right away, we could have been done with this already, and we're kind of wasting patients' time. But that may be you kind of have to advocate for yourself, as whether it's with your own physician or uh, your therapist. You advocate for the patients, and a lot of times you'll say, hey, your shoulder is something hurting you a lot, or your knee or whatever it may be. You need to see a surgeon on this just to see what it is. And because I mean, we both don't want to be wasting our time for the patients. We want them to get better. And so that may be the one thing that people don't understand is you have to advocate for yourself and your choice in your own care. It's not your doctor's choice, it's your choice. So patients need to stick up for themselves and say, hey, I want to see this person, or I want to see this person. And if you know that you're going to get good care by doing that, go for it.
Yeah, absolutely. I completely agree with that. Now, do patients even realize they have options when it comes to where they get surgery? As far as, I mean, obviously at different locations or different businesses, but hospital system versus, your own surgery center.
I don't think they know that there's such a huge cost difference, for sure. We have had people that have like called our surgery center and they say, hey, I like your surgery center idea, and you have prices and everything, but like my doctor doesn't go to your surgery center, or my doctor's not
Yeah,
credentialed at your hospital. And so
sure.
that's a limiting factor. But I think, part of it is the big health systems are starting to employ more and more physicians, because that means that the physician is to some extent under their control. So they have to operate as an employed physician at one of the hospital systems facilities. And that's why they hire the doctors, because they want to control the flow of money into the practice and
Yeah,
into their hospital system. And, I mean, if a hospital comes in and buys a physical therapy practice, for instance, all of a sudden the value of that practice is quadrupled because the hospitals can charge more for it. So a lot of physician groups are seeing dollar signs, and so they want to get bought up by these to be employed physicians for a hospital group or a system, and they don't realize that that's increasing the cost for all of us, because these big health systems and groups are charging more.
yeah. Now, what are ways that or strategies that you guys have used to control those costs in your own center?
So, I mean, this is just an example, but so when we do a joint replacement, we put metal implants into people, and those things are very expensive. And we, as physicians, negotiate directly with those companies to get a lower price for you. And to be honest, we have to, because we're not paid the same amount of money as a hospital is for the exact same procedure. So if we get paid a third as much as the hospital system does, well, let's negotiate, because I can't pay, the price that you pay for these implants, thousands of dollars, because then I'm not going to make a profit and I can't stay open for my surgery center. We got employee costs and all that. So we have, that's one of the examples. We have less staff because we know how many staff we need. And those staff are only focused on the patient. So we don't need all the ancillary staff that a hospital would, and the 24/7 and all that stuff. We still have all the same things from surgery, all the same anesthesia equipment, all the same emergency equipment for the surgical process, but we don't have the stuff that we don't need. And that's a big cost savings.
Now, one thing I've heard people talk about before is, they have their surgery, their insurance covers their surgeon, but anesthesia in the room wasn't covered. They're out of network, or someone else was in the OR and that's out of
Yeah.
network. And so now they've got this excess charge. Is that something that you guys are
Well, yeah, I mean,
constantly thinking about? I'm sure you are, but
Well, yes, because we control our own anesthesia. These aren't two separate groups. These
Yeah.
work with us directly, but
Yeah.
that's happened to me. My wife, I think, got some dermatology thing, and the dermatologist was a network. But then when they biopsied and took it and sent it to the pathologist was out of network, and we were charged like $2,000 for this
Yeah.
pathologist to look under the microscope and see this little tiny thing.
Yeah.
And then normally insurance pays the pathologist $200, but since we were out of network, that's just they raised the price. So absolutely, we have a bundled cost. So when you come to our surgery center, this is your cost. Now, whether it's pathology or anything, all that stuff is included. So those prices are included. So when we quote you the cost before the surgery, that's your cost. And
Yeah.
heaven forbid something goes wrong or something like that where there's an extra charge, but we tell you all that stuff ahead of time because I hated that as a patient. When you go to the
Yeah.
doctor, you ask everybody, hey, how much is this going to cost? And they're like, well, I don't know. It's up to your doctor's, billing criteria.
Right.
So we tell you ahead of time, and you will go in knowing all the in full costs beforehand.
Yeah. Yeah. And to your point there too, it's not like you pick the pathologist and who, like
Exactly.
they
Well, you
just send it
can't
off.
because,
Right.
yeah, this is who they use. And then you're kind
Yeah.
of in trouble because I didn't think that I needed to call the pathologist and say, hey, are you in network with me?
You're right. Yeah. No
No,
one thinks about it. And the average person wouldn't even
they
know,
have no idea. Exactly.
Right. Right. It's one thing for a physician, but even then, like, how does that,
I know.
this it's impossible. You can't do that. So, yeah, I'm glad you brought up the bundled pricing too, because that's something I wanted to ask you and see if
Yeah,
that was something that you guys did, because I think it's interesting. It's that transparency that we talked about too. It's upfront. People know exactly what they're getting, what the price is going to be. It's that like surprise bill 3 months later, right? That no one wants. And
correct.
so,
Correct. There's no other industry no other service industry that you go into a process that you have to pay for that you don't know ahead of time what are the costs. I mean, you get estimates from your contractors. You know how much a gallon of gas is. You know how much you're going to pay when you go to the store to buy something.
yeah,
But that's not the case. Even me as a doctor, I understand insurance, and I still have no idea how much stuff costs
yeah,
because every insurance cost is different. Each insurance is charged
right,
differently. I charge different insurances differently.
right,
It's impossible. So how can that be a legit thing?
yeah,
Not to get into politics, but even the politicians have said this is not fair for our constituencies to
right.
get their procedure done and then they get this massive bill. It's not fair at all.
Yeah. I did a podcast with Dr. Vanderveer from Exemplar Care, and that
Yeah, he was in my med school class. He was a
was
good
he
friend of
really?
mine. Yeah,
Yeah.
yeah.
Yeah. So he used the same example. So a patient of his asked him, what's this? I can't remember what a lab, what's this lab going to cost me? He's like, I don't know.
Yeah.
No
Yeah.
clue. And,
Well,
and
and
so,
he was the pioneer of this in the Des Moines. I'll give him props for this because I even send my wife and my kids over there to get labs drawn because he had this own thing right there, and he's like $7, for like a basic CBC or
yeah.
something, and then where you get medicine, it's like $3, and you go to the pharmacy down the road and it's $50 for the
Yeah.
medicine and
Yeah.
200 for the lab. So I give
Right.
him props for that.
Yeah. That's it. Well, this could apply anywhere in healthcare too, but I'm going to use my insurance. It's going to cost X amount, but if I just say, oh, I'm cash pay, well, now the price is completely different. And
And lower
oftentimes,
most of the
yeah, as I say,
time.
oftentimes significantly cheaper, especially in the case of pharmacy, like usually it
Yep.
is. So,
And you can negotiate those costs. You can say, well, I'll pay you Medicare rates
yeah,
instead of your insurance rates. And they'll go, okay. And it's hundreds of dollars less.
right. Yeah, it is interesting for sure. Where would you say insurance companies help, and where do you think they make things worse?
I think, yeah, obviously insurance companies help when there's a massive disaster. If you have a car accident
Yeah,
and, you have to go to the hospital and you're in the ICU and it's literally $100,000 a day for your
yeah,
ICU bill. I mean, that's debatable whether it should be that much, but still that's where insurance companies help because they
sure.
negotiate those prices and can help you as a patient and help pay for those costs that no one has.
Yeah, that catastrophic coverage, right?
Exactly. But unfortunately, that's what we're all paying for. I mean, we pay, I mean, I don't know what exactly mine is this year, but I paid over $20,000 in premiums for my family for throughout the year for just to be covered. And we use it like 5 times a year to go see the doctor, and the total bill would be, $500.
Yeah,
But I'm paying 20 grand for that catastrophic coverage just because I
right.
have to have insurance.
Yeah,
It's not like it used to be when we were 22 and go get our insurance, and it was $90 a month and it covered everything. I mean,
Yeah.
that was literally what it used to be.
Right.
But maybe I'm aging myself. I think we're about the same age, but still.
Are there injuries you're seeing more of now compared to 10 to 15 years ago?
I think lots of younger sports players, you'd probably know, you probably say the same thing, just these kids that are training incredibly hard at an incredibly young age in the same sport. And I
Yeah.
think all the research shows that those kids, if you are just a one sport athlete, that is not good for the athlete themselves, whether it's in their development mentally or physically.
Yeah.
I see lots of kids, especially around the time of puberty, where their bodies are maturing and they still have bony growth plates. They'll have growth plate injuries or, tendon avulsions because they're out, benching 200 pounds and they're 13 years old and they're taking their, BP 157, protein aminos or whatever, and all this. I'm like, oh my gosh, this guy's like a machine, and he's 13 years old. So I mean, you'd say the same thing, wouldn't you? You see that too?
Oh, yeah. Before you even said it, I was thinking specialization for sure. I mean, we just had a patient in here with, he was probably 12 or 13, but little league shoulder and just pitching like crazy.
And you tell them to take a break, and their dad or mom is like, well, he's got tournaments, how are we supposed to do this? And the kid's was sitting there kind of with his eyes open, like,
Yeah.
I'm not sure I want to
That
play. You see
is,
it on their face, but
yeah,
this
that is
pressure, I mean, this whole,
100%. That's 100% how this particular patient and the
yep.
interaction with the parents went. Yep.
NIL dollars. I mean, I'm telling you that their
It's,
parents are preparing their retirement on these kids.
yeah, right. Right. Yeah, it is. It's something else. What you kind of spoke about a little bit more towards pediatrics, but peptides is a big topic. People ask me about it all the time. So what are your thoughts on peptides, GLPs, all that whole kind of realm?
Yeah, I mean, you kind of said it. You have to sift through all of this data that's out there because anyone can Google or use AI to get a good understanding of this. And that may be a good thing for AI because it can get a lot more data together than you can if you look up all this stuff. I would say the peptides and kind of the hormone replacements, we've seen lots of those. I've seen a lot of my younger men and middle-aged men use those around their time of surgery. In my opinion, I guess according to the American Academy of Orthopedic Surgeons, the AAOS, those really don't have much of an effect, at least that we know of yet. It's still a new thing. And some of that stuff, I mean, none of it's regulated by the FDA, right? So you can go and get this BP 157 stuff,
Yeah.
and you don't know if it's real or not. I mean, same with the GLPs. I think there's all these pharmacies compounding this stuff, and as some medicines would work great for others, and then they get another injection, it does nothing. It could just be saline. It's
Yeah.
hard to say, but
Right.
in all the things that I've read about it, I'm not saying it doesn't work, but I don't know that it does work. So
Yep.
I think that's yet to be determined. I think the old adage in orthopedics is don't be the first one to use something, but also don't be the last
Sure.
because then you're behind the curve.
Yeah. Yeah. Got to jump on that train at the right time, right?
What do you think about the stuff? Do you think it's similar to that?
Yeah, I would agree. And I think most of, I've had some other people on the podcast, other surgeons on the podcast, and they've all basically said the exact same thing.
Yeah.
And that's kind of what I tell people too. It's just, we get patients that come in here and they, one will rave about it and the next one will say, I didn't do anything. And so
Yep.
it's all over the board. And so it's so hard to say whether it has a positive effect or not. Or like you said, it's not regulated. So what are we actually getting?
Yeah. Well, the one thing actually now that is can be regulated, the GLP-1s that basically really help you lose weight, those have actually been very interesting to me because there's lots of new orthopedic joint replacement literature that shows that those benefit our patients, not just in the weight loss, everything, because, if you're over a 40 body mass index and have a joint replacement, you're at an incredibly high risk of getting an infection, whether it's a hip or a knee replacement.
Mm-hmm.
So bringing your weight down actually minimizes that risk. So the GLPs have really been a powerful tool to help people lose weight to get their joint replacements. Not only that, but the GLPs also kind of have this overall body inflammatory, de-inflammatory response. So it kind of calms down inflammation throughout your body. So people can feel really good with those things. And we're looking at how those medicines benefit patients during the perioperative period in joint replacement, because they could
Sure.
be a very valuable tool.
Yeah. Do GLPs have an effect on bone density?
To my knowledge, no, but once again, they're still a relatively newer
Yeah.
medication. So I don't know the answer to that one yet, but I have not heard of any good literature
Okay.
showing that it
Sure.
has.
Sure. I know one topic in the physical therapy world with GLPs is just a loss of muscle mass and how that's going to affect people long term. And so I think that's something that we've been watching and just kind of watching and waiting, I guess, to so to speak, because
Yep,
we just don't
that's
know.
sure. That's a big. I mean, they're eating a lot less calories, and when you don't eat enough calories and protein, what do you start to lose fat? And then after you start losing fat, then you start losing muscle, and that's the big thing. And so, one interesting thing about that, we have seen there's a correlation in orthopedic, just a one example between GLP-1 and weight loss, as well as perineal nerve palsy. So they lose a lot of weight.
Interesting.
All of a sudden, the perineal nerve starts draping over more over the fibular head, and then they
Yeah.
start to get a foot drop. And I've done probably 5 or 6 surgeries in the last couple of years on patients who have lost a lot of weight. And then they start developing this tingling numbness on the top of their foot and they start developing this foot drop. So we have to go
Yeah.
in and do this perineal nerve release and then things improve. But we're actually doing a study on that right now, me and a medical student at the University of Iowa on that exact topic. So it's kind of interesting. I mean, a lot of these things will come to light, but
Yeah.
you just want to prepare your patients for when they take that and what the next step
Right.
is.
Right. Yeah. That's really interesting. I hadn't heard of that. So I'll be looking forward to that when that
Super
comes out.
exciting, I'm telling you.
Yeah. It's interesting though, for sure. Yeah. Aside from GLPs and peptides, is there anything in the orthopedic surgery realm right now that you think is mostly hype?
Yes, and I'm probably going to be crucified by my profession for saying this, but I think PRP is a ton of hype. All these PRP injections, if you look at the literature, and this is one powerful tool of AI, if you go and say, hey, show me all the evidence for platelet-rich plasma injections in arthritis, and it will show you that there really is not a whole lot. Compared to placebo, it like does the same thing. What are like the American College of Rheumatologists and Arthritis says they recommend against PRP for arthritis. The AAOS, it's kind of interesting, but we do lots of those injections, so they're a little bit less negative on it. They're like, well, we're not sure if it works, but you could use it on mild arthritis, and it may have a short-term benefit, which at the most positive, that's what it is. And what is benefit? Well, they use like this BAS pain score system. I don't know if you've ever seen that. It has like a
Yeah.
happy face, which
Yeah.
is 1. It's like a really angry face, that's a 10. And
Yeah.
then patients circle the number, and that's the benefit. So the people with PRP circled like a 5, and the people with the saline injection circled like a 6.5 or something. And
Sure.
I mean, that to me, that's horrible evidence. Like that's a circling. I mean, it's sunny outside.
Right.
Hey, I'm going to circle a 6 instead of a 5 because I feel better. So that in my experience, any arthritis injection for PRP really doesn't do a whole lot, and it's expensive. It's out of their pocket. Typically, it's around $800 to $1,000, I think is the average price around the metro area. And there's a lot of hype to it, right? They use it as advertising. You don't need surgery. We've seen all these commercials on the radio and television for this stuff. It's just, unfortunately, if it actually worked, I think we'd all be doing it. And it's the cost of some of these things is outlandish. So it does work, on the other hand, on things like patellar tendonitis and like lateral epicondylitis, tennis elbow. It can work with those things and maybe even potentially save surgeries on those things. So that's one thing that it may be worthwhile in some of these tendinopathies. But as far as arthritis, in my opinion, it's just a money-making tool for a lot of the surgeons.
What about when you have things like an ACL or rotator cuff? Does it have a place with those surgeries?
Yeah, I think a lot of surgeons use PRP to augment those repairs. Like rotator cuff, they'll do the repair and then they inject some PRP. In my experience, especially for talking about rotator cuff repairs, I think it's just an added cost. And so a lot of physicians or the surgeons will charge, work comp. They'll do it for work comp because somehow work comp pays for that. And it's like $1,500 and it's just a way for them to get more money. And I don't think there's any good literature that shows that PRP really helps the repair if you do a good rotator cuff repair. So I'm not sure that that's needed. ACLs, if you're using an allograft, a cadaver tissue or something like that, And I've heard of docs like soaking the graft in the patient's blood beforehand or getting some PRP and rolling it in that.
Yeah.
But I mean, if you're using an autograft and you're drilling into their bone, like that's PRP for me. Like I'll rough up the bone surfaces and put that graft right in there. That's going to grow in so nicely. So I think to me, it's a added cost, and I'm not sure that it benefits in any of those. I don't know that there's anything wrong with it, but it's just an added cost.
Sure. Yeah. What are new techniques or technologies that deserve some attention?
Ooh, that's a really good question. Can I maybe start with what doesn't deserve our attention? Is that
Absolutely. Let's do it.
because I'll preface this whole discussion with, new technologies are great. We have to have innovation, but new technologies are really expensive and they tend to come from industry. And industry makes money on new technologies because they sell it to the docs. The docs use it and they sell it to hospitals. One of those, as an example, is robotic surgery. That is a huge, hey, I use a robot. I'm really technologically savvy. It makes you better. It's less invasive. Well, that is absolutely not true. There is no benefit that any study has shown, at least any legit study has shown that there's any benefit between an instrumented total knee, which is just the standard way we do things, and a robotic total knee, other than cost, because you have to pay for that robot. Most of these robots are over $1 million. So the hospital or the surgery center will buy that. Then they have to pay like a $10,000 monthly fee for upkeep of the thing. And then
Goodness.
every surgery they do, there's disposables, like a big plastic thing that's sterile that goes over the top of the robot. And then that company that sells you that robot, you have to use their implant. So they're making money off of you for that
Of
too.
course.
So, if it and I still use it every now and then on the right person, but it's maybe been a year and a half since I've used it because I do hundreds of joint replacements every year. And my partner, Dr. Fish, he always says, do you need a GPS if you're going to the grocery store down the road? Like, in other
Yeah.
words, we do knee replacements and hip replacements all the time. And
Right.
I'm not saying I'm perfect, but we're pretty good at doing that. So
Yeah.
I don't need to use the robot when I'm just going down the road. But if I've got some really big deformity that is a non-standard surgery, a robot could help you with that, but it's certainly not needed on every case. So that's the technology I think that we don't need to focus on. Maybe I would say the trend that maybe we should focus on is, and it kind of gets back to the earlier topic, is outpatient surgery. I think outpatient surgery in general, not doing surgery at a hospital, but going to a surgery center and doing it and going home the same day. Even Medicare has just, I mean, a ton of orthopedic surgeries have now gone onto the outpatient surgery only list. So shoulder replacement, hip replacement, knee replacement, all of these, you go home the same day and you do it at a place where healthy people are, not where a place where sick people are at the hospital.
Right.
So that is a huge trend. There's more surgery centers coming up across the nation. Even hospitals are opening surgery centers with physician partners because they see that trend going. So they don't want to, lose money out of it. So
Yeah.
that's maybe the trend. As far as like, I don't know, I'm thinking of other like sports related things or other joint replacement things, but that I would just say there's a lot of hype out there for a lot of new technologies, but the proof is in the pudding and the research and the time. I mean, there's like ACL repairs now instead of ACL reconstructions. So with using these special types of things, I'm not sure that there's anything in that. There's stem cells. There may be some cool stuff in the future, but that does not bear out in orthopedics yet. That has negative evidence against it.
Yeah.
There's bone marrow aspirates where you take and inject into joints. So a lot of this regenerative medicine, I think, there is some promise, but the promise is not results. Maybe there will be results. So just be cautious if you're getting into some of that stuff. If any of the listeners will recommend that stuff, it's an excess cost, and you may not get good results from it.
Yeah. Yeah. That seems like a big money maker nowadays. There's a lot
For
of
sure.
kind of independent groups popping up, even here in Des Moines, that offer those services.
Every few years, there's a new one that comes in because I've
Yeah.
seen multiple of these kind of PRP
Yeah.
injection regenerative stuff come in, and they're all owned by big private equity. That's
Yep.
the interesting thing. They hire these local doctors to come and work for them, and they charge thousands of dollars for these injections,
Yeah.
and it's a money maker.
Yeah. So how do patients separate out the good information from just marketing?
That's I mean, that's hard for me to do sometimes, to be honest,
Yeah.
with
Yeah.
all the
Absolutely.
companies coming to us and selling us their
Yeah.
certain types of stimulation things to increase blood flow, like what is real, what is not.
Sure.
I think, I mean, you have to be incredibly careful when you're reading the research because, like, who wrote it, who did it. That study may be true for those people at that time at that institution, and what are their motivations? Is it by the company that made this product? That's probably not a good study. Or was that company paying someone to do the research for them? That's you got to be careful with. I think one of the more important things is trying to finding a surgeon that you know and trust that can see through some of that,
Yeah, for sure.
and maybe getting multiple opinions on it too, because I think we probably have similar ideas on most things, but you may have some experience that I don't have, and I like to ask other professionals about, hey, what's your experience with this stuff or with this product?
Yep, absolutely.
There's no easy way to do that.
Yeah, it is. It's confusing too. Um, I mean, like you said, just even for people like us that are in healthcare and we've been in it for a while, when it's
I know.
confusing for us, like how's the average Joe gonna wade through that information? They're not gonna know how to read a study and actually tell, is this a good study? Is this not? You know,
I know. Well,
it's a confusing
that's for
world.
sure.
Yeah.
Yep.
Yeah, absolutely. What has changed the most in orthopedic surgery since you've started practicing?
Ooh, that's a good one. I think, from my first surgery that I did in 2009, just the time spent in the hospital is probably one of the biggest changes. Just as an example, a knee replacement might spend 3 or 4 days in the hospital when I first started doing knee replacements. And there's more blood clots, more infections because people were just sitting in this dirty hospital room for 4 days. And then they would go to a rehab center or a nursing home, is a better way to put it, and just get
Yeah.
sit there and rot basically.
Yeah.
Oh, and I still can't believe it, but I mean, we do these surgeries. They start at 7:30. They're out of the OR at 8:45. They start walking at 10:30, and they go home at 11:30 after a joint replacement. It's unbelievable nowadays, and people do so much better. And I'm so proud of that we do that. But that
Yeah.
took a lot of, I mean, that's near 20 years now of innovation, and COVID drove a lot of that too because
Yeah.
you couldn't do surgery or anything in the hospital during that time. So that pushed
Right.
everything to surgery centers. And then we found our research showed that these people did better. The patients were happier, less cost, less infection risk. Patients slept in their own bed. They weren't being woken up to take their blood pressure all night and all that stuff.
Yeah.
So
That's interesting.
truly, that's one of the most probably that and maybe even the longevity of our joint replacement implants now. When I first started, they'd say maybe 15 years, and now they've really honed the quality of the plastic and the metal and the ceramic that we put into people. And those things can last 30 plus years now. So
Wow. Yeah, that's amazing. Are there surgeries being done today that you think we'll look back on in 15 years from now and question?
absolutely. It goes back to medical school, and they're like, the first day of medical school, they sat us down. They're like, we know that 50% of what we teach you right now is not right. The problem is we don't know what that 50% is. So, I mean, I don't know. I'm trying to think of a specific surgery that I
Yeah.
think is maybe questionable, but I also think there's probably surgeries 10 years from now that we will do that we are not doing now. I don't know. There's several different examples. I'm just trying to think of one. I think one of the, not necessarily a surgery, but like it's more like how we treat patients. I just think back to COVID when I had like a 92-year-old guy that I fixed his hip after he fell and broke his hip, and they would not let patients in the room or the patient's family in the room to go over the discharge stuff for this patient. And so he's 92 years old, totally demented, and they were telling him how to discharge, and they wouldn't let family in the room.
Wow.
So that it goes back to this transparency stuff, right? I mean, like
Yeah.
include the patient, include the family, include everybody, explain things, discuss things. I think that's this transparency of the entire process and the relationship with the surgeon and the institution to the patient. I think that is changing and that will continue to develop.
Yeah. Yeah. I love it. Well, Dr. Peterson, I want to be mindful of your time. Is there anything that we haven't talked about that you'd like people to know?
I will. Let me ask you a question. I mean, I want to throw that question back
All
to
right.
you. I mean,
Sure.
what from you tell me about your experience with us as orthopedic surgeons. Like, how could we communicate better with our physical therapists?
Yeah.
What do you see us doing that's good, and what would you want us to increase or do better
Sure.
at?
This is a great question. I'm not just blowing smoke here. I don't know if it's capitals I don't know if it's your EMR, your system, or maybe you just have an SOP on this or what, but I know when I send a patient to you guys, I'm going to get feedback right away. The note, there's oftentimes Reynolds, for example, he'll text me and say, hey, this is what's going on with this person.
Yep.
5 minutes later, boom, I've got the note. Or we've had it where, you know, 9 a.m. I get the note from the patient. 10 a.m. they walk in. Oh, hey, I saw the doctor. I'm like, I already know. Like, yeah,
Yep.
I already know
Yep.
they said this, and this. And they're like, how do you know? I'm like, they already gave me everything. But the communication with Capital is so amazing. I don't, we'll send plan of cares to doctors elsewhere, and eventually we'll get them back. But
Yeah.
everything's so quick, and I know exactly what's going on with those patients because it's already been communicated, and everyone's in the know. It's great.
I
So
appreciate that. I mean,
yeah,
I haven't tried to do much marketing. I haven't even said Capital yet, but yes, I work at Capital Orthopedics, and I didn't want to take advantage of your platform, but
yeah,
I
no,
mean, that's what we pride ourselves on. We are not a big group.
yeah,
We're not 30 physicians with 250 employees that your message to the doctor has to go through 10 people first. No, like
right,
it comes right to either my nurse or me, and we communicate and we go right back out, and we try to do that for our patient, and that is our niche.
yeah,
That's how we do well with our patients. So
yeah,
it's nice to hear that, but tell us
yeah.
how we need to improve. You got to get to the brass tacks here.
Goodness, how can you improve?
Like any of our orders that we send to you, or that when we send you a rotator cuff, we try to be specific, like, hey, I repaired the subscapularis. Make sure that you limit external rotation.
Yeah, I
Do you
always I
see
always
that stuff?
appreciate that. It's nice when it's, hey, I'm not going to give you this set protocol and you have to go box by box. I appreciate when it's like, hey, you're the expert, you do the rehab, but I don't want them doing forward flexion past 90 degrees until this date. Like, okay, I can do that.
Sure.
So it's nice to know, like, hey, maybe this surgery was a little bit more involved. There was something that we saw once we got in there and that we didn't know ahead of time, and so I think that's very, very beneficial.
Do you like it when we say, hey, I did this surgery? I may send a protocol, but part of it is just like, hey, if I know and trust you, like, you know what you're doing, go for it. The problem is if I don't know the physical therapist, then I'll try to send them a protocol and
Right.
communicate as best as I can. But
Yeah.
what do you prefer in that?
Yeah. Yeah. I feel like I've been doing this long enough, so I kind of like it. And I was in the Navy before this, and I guess I'll give one story here. Like when I was a brand new physical therapist, I don't even remember I think it was like a Macy procedure. I walked over to the orthopedic surgeon and said, hey, like, what do you want me to do here? Like, I was used to all the protocols on the civilian side from my clinical rotations, and used to just surgeons saying, you got to do this, this, this. And so I get in the Navy, and I hear I've got a patient sitting in front of me. I'm like, I don't know what to do because they didn't tell me what to do. So I walk over and talk to the surgeon, and I remember, I just clear as day, I remember him spinning around in his chair and just looking at me, and he goes, well, you're the expert, figure it out. And he was like, what do you want me to do? He's like, I can Google a protocol. You want me to Google it? And I was like, no, like, no, sir, I'll take care of this. But so
That's
that's kind of
funny.
the environment I was raised in as a physical therapist, was just like, you're the expert, you figure it out. And so I kind of appreciate that, for sure. If there's set things that you don't want done, I want to know that. But otherwise, if it's like, hey, you've got free reign, like, do your thing, let's
Sure.
go. I kind of like that. But
And you don't have to use names or anything, but give me an example of like how different doctors will say completely different things for the exact same procedure.
oh yeah, I mean, if I'm sure it happens within Capital as well, but a rotator cuff um from a certain surgeon
Whomever.
at Capital
Yeah.
is going to look completely different from a surgeon at DMOS. And like I said, it could be any group really, and it's so different between surgeons sometimes. So um not all rotator cuffs look the same. Not all, I mean, no surgery is the same, right? But some of those protocols look pretty different afterwards. So
Do you see good and bad protocols or things? Give me an example of one thing you would change about a rotator cuff protocol.
yeah, I think there's probably pros and cons to all of it. I prefer, getting people in here early, getting them moving versus letting them sit for 6 weeks. Or we have had the opposite of that too, where we get people, they'll give them the green light to come in, but then they're so limited on what they can do here that's like, well, kind of burning through your authorized visits from
Visits. Yeah.
insurance when I can't really do anything. So it's like, do you need to be here at this point? Like, I don't know. So there's kind of a happy balance of that, I think, of, allowing them to do some stuff, but not doing too much. And obviously that's going to depend on what that rotator cuff looked like when they got in there for the surgery. But
Yeah, I've had some that have just been completely blasted, and you have to put
yeah,
a ton of anchors in, and then you want to let those people sit for 6 weeks because
yeah,
you'd rather have it heal than get them moving too fast and just the stitches rip out of everything.
right. Yeah, exactly.
But yeah,
Perfect. Well, if people want to learn more about you or find you, how can they do so?
sure. There is, you can go to our practice's website. It's Capital Orthopedics and Sports Medicine, but our website is DSM, like Des Moines, dsmcapitalortho.com. And then if you want to look at our surgery center, it's Advanced Surgery Center that's in West Des Moines. You can just Google that and all of it comes up in there. So right now we're working on posting all of our prices directly online. So like let's say you do have a knee replacement or you do need a rotator cuff, you can look and just see the exact cost for the entire process right
Yeah.
there online.
Yeah. That's amazing.
Same at Capital Ortho, we're doing the same thing, and we're trying to be as transparent as possible because I'm also a patient, and it drives me crazy when I can't. You don't know what
Yeah.
things are going to cost.
Right. Right. Absolutely. Dr. Peterson, this has been amazing. Thank you so much for taking time out of your busy schedule to be here.
Yeah, happy to do it. Thanks for having me. I had a great time talking to you. Thanks for your expertise with
Yeah.
our patients.